cause some, or bring everyone some reason for reconsidering maybe what they're doing and how sure they are of what they're doing, because now I've done that to myself. I mean, I guess oops, oh, yeah, going here. The real issue here is one of my favorite quotes is "Nothing destroys confidence like follow-up." That was actually, I think, originally a quote by Dubois, who is a very famous original spine surgeon in France who created the CD instrumentation, one of the earliest instrumentation sets. And I think it holds for all of life and certainly medicine. So that's really going to be the theme of what I'm talking about today. And what I'm going to be talking about is the cliche. And it's a term we made up, and it stands for clinical intracranial hypertension episode. It's the nuts and bolts of what we do in brain injury when we look at the clinical aspects of traumatic brain injury treatment, at least in terms of ICP, and also the research aspects when we start asking questions like, what is the proper treatment threshold? What's the definition of an insult? What insults are actually harmful, etc. I want to thank my co-conspirators in this, Rob Bono, Nancy Temkin, Jason Barber, and Christine Park, who have worked now for quite a while on this. We made the discovery of what I'm going to show you, and then because of its nature, we've spent a lot of time trying to make sure that we didn't make any errors, because we don't want to stir up a hornet's nest that turns back on us. We started out to do something somewhat different. In brain injury, the therapeutic intensity level is an attempt to quantify the amount of treatment delivered to an intracranial hypertension episode in a patient. So basically, you have mannitol, hypertensive saline, CSF drainage, blah, blah, blah. And all those treatments are either given 1 point or given variously weighted points and added up so that you not only have the amount of time over an ICP of a certain threshold, but you also have a measure of how much treatment is delivered. Now, that's important in simply knowing what happened, but in a way, it's also a measure of ICP resistance, because once ICP goes above a threshold, it's not just ICP anymore, it's resistant ICP. The only reason it's still elevated is because it's staying up despite treatment. And that changes it quite significantly and hasn't really been well dealt with in the literature. Well, we thought that we could use large language modeling to develop a weighted system to describe care and treatment. In other words, with using a large data set, we could take individual treatments and assign weights to them, and then use them as a prognostic variable to adjust the ICP that was above threshold for its degree of resistance. It's been tried various ways in the past, and it's never quite worked, even though all of us believe it should. That's what we started out to do. And we picked the Boost 2 trial, which is the prospective randomized phase 2 trial of the brain tissue oxygen monitor. We picked that trial because it was very well done, large number of patients, and was available because Nancy was the data statistician and Jason was the data manager. And we also picked that trial because that trial did very high quality clinical data collection, but also in the background, it streamed high resolution electronic physiologic monitoring. And so when we started to dive into that with respect to looking at the therapeutic intensity level, the TIL, we found interesting patterns of treatment when the ICP went up. Treatment, the patterns of which probably interfere with analyzing TIL. We actually printed out run sheets for a whole bunch of patients and tediously went over them individually to get a feel for what was being done. And that's sort of feelings that maybe we're not understanding what we're actually doing. And actually, that's become a second project. I'll talk a little bit about that at the end of this talk, because the patterns of care for intracranial hypertension are probably not what we would like them to be. In any case, in attempting to codify the ICP courses so that we could look at the TILs, we found that looking at the electronic data in parallel with the clinical data led to some interesting findings. So let's just look at what is a treatment period. There's a pre-cliche period before the ICP has gone up. The ICP is okay and the patient's just being managed. And then there's the onset of a cliche, clinical intracranial hypertensive episode. And in the BOOST trial, that was defined as 5-minute continuous abnormality of elevated ICP using less than 20 as normal. So 20 or greater was intracranial hypertension at that time. So 5-minute continuous abnormality, not due to iatrogenic or reversible maneuvers, unless those persisted after the maneuvers were over. But that led to the diagnosis of a cliche and the necessity of considering treatment. Then there was the treatment window. Once that had been defined, once the patient had been defined as being over 19, 20 or greater for 5 minutes by the bedside clinician, then the cliche was officially on, and it was then monitored. The treatment had to be started within 15 minutes of the definition, and it ended when the ICP went to less than 20. I'll talk a little bit more about that in a second, but for the purposes of our study, for the definition of our cliche, we defined a form thrust cliche. We wanted to look at the simplest ones first so that we could get our foot in the door. And we defined that as a maximum cliche duration of less than or equal to 60 minutes. So reasonably short cliche for the purpose of this study. If it stayed up at greater than 60 minutes, then there had to be at least one treatment of a higher tier, generally tier 2, and that's the way the course would play out. But we artificially stopped ours at the end of 60 minutes. So at the end of this period, wherein a tier 2 treatment would have been required. Now, a couple of things we looked at. We looked at the bedside clinician's definition of the cliche defining period. So the bedside clinician said, oh, the ICP has been over the threshold for 5 minutes, so the period is defined. But because we had electronic data in the background, we also went back and looked at electronic data for that period. So the average ICP over that defining period, sort of a way of back-checking the bedside clinician's definition. And then for the cliche itself, the period itself, we again had electronic data. And so we could look at the average over that interval, whatever it turned out to be, less than or equal to 60 minutes. And we could look at the maximum ICP over that period. So we could get a little more information about what happened when the bedside clinician had defined the cliche, had said there is a cliche in existence. Then the electronic ICP-5 was collected in the background. It was not used for this definition. So this is the definition we've been using forever, where the bedside clinician said, oh, the ICP is up and has been staying up for a certain number of time, depending on the operational definition at that time. And that sets off the cascade of treatment and investigation. So essentially what we had was the penguin in the background, the electronic penguin, who was dealing with Jake and Elliot in the foreground. This would be the bedside clinician, and this would be the electronic data capture in the background. And this was the first time we kind of had a tattletale in the background to see what was actually going on in a well-done prospective study. The way the study was set up, the definition of form thrust cliches that we studied where episodes were type B, which in the treatment algorithm meant that because this was a 2x2 study, ICP and brain tissue oxygen, brain tissue oxygen was normal. So all we had was ICP abnormalities. Type C is abnormal brain tissue oxygen, etc. Then we had the total duration of episode. As I said, we limited it to less than or equal to 60 minutes so that it wasn't an episode that went on forever. It only required minimal treatments, which in the treatment algorithm used in Boost, which was very similar to the CBIC algorithm that we subsequently developed that had 3 treatment tiers. Only tier 1 level treatments were delivered for this. So it was really form thrust. It was really the most common and the easiest treated ICP episodes that we deal with on a daily basis. We adopted the episode definitions from the Boost 2 manual of procedures. So beginning and end of episode timing was taken from the case report forms as part of the study. Now, the one caveat here, and probably the major limitation in this study, was everything was well defined except for the end of episode. That was really when the nurse decided, the bedside clinician decided, that the episode was over, that the ICP was no longer maintaining above the threshold. As you can imagine, in a clinical situation where the bedside clinician is busy and has other things going on as well, that may or may not have been reasonably instantaneous with the end of the episode. So the bedside clinician could have recognized that now the ICP is down, but they may have been busy with something else and not recorded immediately. That's a possibility. And that's probably the biggest problem that we faced and couldn't resolve by maneuvering through the data set. And then ICP data was acquired via fiber optic sensors. So it was either a camino intraparenchymal or Ventrix, which is the EVD version of the intraparenchymal monitor. But it was always fiber optic, and so it didn't require zeroing and et cetera. And then either continuous or intermittent CSF drainage was allowed based on site protocol. The definitions again were bedside clinician ICP was ICP recorded by the bedside clinician for the 5-minute period of intracranial hypertension defining the cliché. So if the cliché was identified, it was based on this. The electronic 5-minute ICP was the electronic background of this. That was the tattletale in the background to see what actually was recorded. And then we had electronic data for the cliché itself, for the treated period, the period of intracranial hypertension. And we had the electronic average and we had the maximum. These data were summarized as 1-minute averages. So those are the data with which we'll deal here. And this is what we, interestingly, started to find. This is the bedside clinician 5-minute defining period. And this is the concomitant electronic ICP-5. And what you see is, in the best of all worlds, both would agree. By definition, the bedside clinician did not have any episodes of bedside clinician ICP average less than 5. But the electronic ICP, as you can see, a lot of them were in concordance with the bedside clinician, but a lot of them weren't. When you start to look at the actual data, you wonder what's going on here, because 53% of bedside clinician defined ICP episodes were not confirmed with an average electronic ICP for that period of over threshold. When you then look at the episode itself, so this is the electronic average for the episode until it was listed on the CRF as ended. And this is the maximum that occurred during that. You get some very interesting patterns here. What you find is you find what would be true cliches, what we expect clinically, what we think should be happening, where the average is high. So by definition, the maximum was high. That would be a true cliche. But we have other episodes. Here we have the average being below threshold and a significant number of patients there. We have a group here where the average was low, but the bedside clinician had called it high. And we have what's going on here? We have another group here where surprisingly, both the maximum and the average were low. So that's well out of track. I mean, it's quite possible here that what the clinician was seeing was the maximum and interpreting it as an average. So they were seeing a lot of high episodes, which didn't average out to be a high mean, but were impressive in the fact that some of these, which might have been very high, were there every time they turned their shoulder and looked at the monitor. When we look at the direct comparisons during of defined episodes, and we look at the average of cliche for defined episodes, we find here a group where the average was actually below threshold for that episode, as we said before. And we find here a very interesting group where the maxima were actually below the threshold for the defined clinical intracranial hypertension. Now, remember, all of these cliches were treated. So they had implications, not just for research or for identification, but they resulted in active treatment with the associated potential complications, et cetera. So what we did then was we said, okay, let's break these down into two groups, idealized and non-idealized. So let's take the idealized one. Let's take the group, the subgroup, where the bedside clinician definition and the electronic definition, the BC ICP-5 and electronic ICP-5, were both greater than the threshold. So by definition, these are the perfect episodes. They match up, BC ICP and EICP. And when we looked at that, we noted that there was still a group, when you looked at the average versus the max, where the average was less than threshold. The max was always greater than threshold because of the way we defined these, but there was still quite a group, 41 or 37%, where the ICP maximum, or the ICP average, was lower than the threshold. So not actually representing what we were considering when we were looking at these clinically, or in research cases that used clinically identified ICP episodes as their study population. The research would have been influenced by this as well. When we again look at BC ICP definitions, and we look at the concomitant averages and maxes for the cliches, we again find abnormalities. We find groups here where the max was high and the average was low. Again, this may be the case where the bedside clinician misinterpreted high maximal values as a high average value. Now, we think in terms of practice and research that these were all high average values, but turns out they weren't. And maybe part of the issue is with the diagnosis, recognition, and eventually decision that the ICP episode has ended was actually based on the bedside clinician's impression from maximal values and not average values. And of course, it's a big ask to ask a busy bedside clinician to do averaging in their head. Now let's look at the other group, the non-idealized cliches. Here we had the bedside clinician's ICP made the definition, so it was greater than 20 milliliters of mercury, but the concomitant electronic data for the defining period was not consistent with the bedside clinicians. So this is what we have, the other half of the prior chart. And this is the association between the average and the max. And again, we see abnormalities. Here we have the true cliches, what we think is always going on. And that's where the average and the max are both high. So by definition, if the average is high, the max is going to be high. The question here is, since this is a non-idealized cliche, where the electronic ICP did not support the bedside clinician, why do we have true cliches then? What actually would have identified these? Is this some non-quantifiable clinical recognition by the bedside clinician of a sick brain? That's an interesting question. I don't know how to answer it, but we did have true cliches, true episodes in the absence of what the electronic system would have identified. And then we had low, average, and high max. Again, the possibility of a bedside clinician error. And then we had something which is really quite hard to explain. We had both low, average, and max. Now, again, these are non-idealized cliches, but again, they were looked at as true episodes. They were defined by the bedside clinician as true episodes and resulted in treatment. And when we look again at the correlation of the defined bedside clinician definitions and the averages and max, we again have these interesting patterns. True cliches. So again, the question is, why were there true cliches? We have these episodes where the average actually wasn't high. And indeed, some of them where the average and max weren't high. So this is really overtreatment. This is misdiagnosis of intracranial hypertensive episodes and the complications of those being treated with one or more tier 1 agents, low risk agents, but being overtreated. So the implications of this, which was rather surprising, and to be honest, because it was so surprising and disturbing, we went back to the two principal investigators, Ramon Diaz-Aristia and Lori Shutter, as well as the clinical nurse coordinator of the entire study, Carol Moore, and went over these findings with them to make sure we were using their data dictionary and case report forms correctly. And we hadn't missed anything. And they confirmed that what we were seeing must be consistent with what was actually going on. But clearly, the clinical identification of cliches is not sufficiently accurate to guide treatment or research. If this high resolution study, well done study done at academic centers with close oversight from the study coordinating center. So really, what should be a great example of clinical management at its best. And again, this is probably certainly due to an overly optimistic expectation that a bedside clinician can perform accurate averaging by eye while managing a patient. We've always made that assumption. It's probably not a good assumption. We saw many errors likely due to overinterpretation of high maximum values despite low average. It's curious that some true cliches were identified following non-idealized defining periods. And this may be clinical acumen, or it may be that we're missing other data that would be more sensitive or have higher resolution. Again, all these episodes were treated, so there are clinical implications of overtreatment. And then such variably identified cliches are probably not reliable sources of research data either. And these are the data that we've used for studies on ICP threshold determination from outcome studies based on number of episodes and magnitude, and also ROC analysis of correlation of area under the curve with outcome. And then the utility of ICU monitoring alternate patient outcomes. We look at people who were treated versus people who weren't treated based on ICP monitoring. Well, we can see now that treatment and actual ICP may not be well related. So those studies also come into question if indeed what we found here is generalizable to other studies. And then, of course, it may not be limited to ICP. Brain tissue oxygen as well, we're doing the same thing. And on all of these markers, we're asking the bedside clinician to make mathematical calculations, integrations in their head while they're busy, and we're asking them to do it by eye. So I'm afraid that what we've done is discovered that the way we've always done things is not optimal, and it's asking too much of a bedside clinician. The implication is we need to to address this. So we need to develop probably a uniformly accepted algorithm for real-time, high-resolution, data-driven diagnostic criteria for cliche identification, probably done electronically based on maybe a consensus-developed, commonly accepted and shared algorithm for looking at what is a properly diagnosed insult, however we define that, and probably analyzed and displayed electronically using, you know, something similar to an IEEE definition of Bluetooth standards or something. But it certainly seems that what we've been doing for a long time is not what we thought we were doing, and this is disturbing. Again, we think that Boost 2 was a great study to do this, and because it represented as high a quality oversight of routine clinical treatment, it's probably generalizable to your average care, either at academic research centers or at non-academic care-only centers. But because we have a little extra time here, I just want to bring on just a little bit more here along the same lines. Well, I said earlier that we looked at individual treatment courses over and over. And so we began to ask, well, what happens when the ICP goes up? True or not, as we've seen now. But what do we do? What actually happens? Well, we usually do something, because that's what we do in medicine. But what do we actually do? Well, this is a waterfall plot of what came out of Boost. And so this is a proportion of ICP episodes, and these are combinations of different treatments: sedation, analgesia, CSF drainage, lowering temperature, adjust head of bed, mannitol, hypertonic saline, PaCO2 at low end of normal, and elevating the CPP. So these individual treatments in combination are represented by this waterfall plot. And the actual incidence, the proportion of ICP episodes that receive an individual treatment, whether with or without being in combination with another one, is represented here. And it's really quite striking here that there are only a couple of combinations that make up the vast majority of treatment of these form thrust cliches. And indeed, one makes up a really striking majority of that group. And this is all eligible ICP episodes. Again, as we defined earlier for the previous study. And so this tells us what we do when the ICP goes up. Essentially, in the vast majority of cases, we dial up the sedation and analgesia. Interestingly, when you look at this and you think about what's going on in the room, these are interventions immediately available to and generally independently applicable by the bedside clinician. So ICP goes up. It's now been up for long enough that it needs treatment. So call house officer, done. But what can be done right now to bring the ICP down without the house officer having to come to the bedside or an order having to be delivered? Well, if you have standard orders and available treatments, that's what you do. And one of the suspicions is maybe that's what drives the choice of treatment, is sort of convenience or availability. And if you look at the treatments that go into this readily available bedside treatment, CSF drainage may or may not be available if you have an EBD or not. But if you look at the combinations that go into this box of things that are at the fingertips, it's actually quite a distribution. Some of them are very low incidence, but still, it may well be that what defines the treatment is not necessarily medical need or targeted therapy, but availability. And if you look at what happens in the first 15 minutes, the same curves obtain. You still see the same distribution. It's still dominated by sedation and analgesia. So this just compares all of the episodes, which are in blue, to the first 15 minutes, which are in red. And I don't think we see anything exceptionally different. So the same sort of parameters that guide treatment or that direct treatment seem to obtain during the first 15 minutes. And again, that would make sense because once you decide that you need treatment, you're going to do the things that are readily available and quickly. You're not going to have 23.4% saline sent up from pharmacy or have RT come by to adjust the blower, et cetera. Now, we've all seen at the bedside this particular troubling scenario where you walk into the room and the nurse is somewhat frustrated and they say, I've maxed out the propofol and fentanyl. The head of bed is at straight up and the EVD is on wall suction. The noradrenaline is at max because you've dialed up the propofol and fentanyl. So now you have to support the CPP with another toxic drug. All of those are in that pink box of readily available at fingertip treatments. Is that what we should have chosen? That's a good question, but that's what gets done. So quote Vademus here. In the area of precision medicine, we should be identifying the cause of intracranial hypertension and targeting it in terms of treatment. That's precision medicine. That's what we do in cancer now. That's what we should be doing in brain injury. It appears, however, that what we're currently doing is identifying the high ICP values and targeting the achievement of near-term lower numbers. In other words, chasing numbers. And unfortunately, even the high ICP values seem to be of dodgy validity. So obviously, the first step in that is to straighten up our identification, accurate cliché identification. Beyond that, we should probably go back to thinking of cerebral compliance rather than just ICP, so that we're not just dropping the ICP, we're treating the compliance. We should probably be thinking in patient-specific ICP targeting, where we set a threshold based on the underlying pathophysiology and what is appropriate to that particular patient at that time in their treatment course. And focus on identifying the etiology of increased ICP. Mannitol will not treat hyperemia due to electrical activity, yet mannitol might be the first choice. Judicious choice of ICP interventions. Again, what drives ICP interventions may be more than or different than what we generally assume to be driving them. And then finally, we wonder, should we be waiting for crisis? In other words, should we be waiting for the ICP to achieve a certain threshold or the ICP brain tissue oxygen, whatever combination, becoming to what we consider a toxic level and then treating it? Or should we be recognizing the issue, which might be recognized in the compliance, and be treating it by titrating it in a tranquility approach? That's something that came up after the BEST TRIP trial, but it's, I think, a decent question. I mean, if you look at the way we treat ICP monitoring now, we don't do anything until it goes over a threshold. And then, as you can see, we add a number of treatments, not all of which are chosen based on precision medicine. And then we crush the ICP back down and we rinse and repeat. And that is our crisis approach. And in between treatments, we kind of kick back and don't think about it very much. Whereas in the BEST TRIP trial, where we had a group of patients that didn't have quantitative ICP, once we had suspected intracranial hypertension based on predetermined criteria, we had to treat it in a tranquility fashion. It was basically majority were scheduled hypertonic agents, which is much more of a tranquility or a preventive treatment method. I'm not saying that's superior, and we didn't really compare them that well because that wasn't the goal of the study. But certainly that tranquility approach could be applied to someone with an ICP monitor as well. We think prevention is an ounce of prevention is worth a pound of cure. Maybe this is true for ICP as well. And that would again bring us back to what our mentors, Doug Miller and Tony Marmer of the 1970s, were telling us the beginning of the ICP dogma. So I think that based on where we are now after these bits of research, we're looking down a kind of an uncertain slope and wondering if we need to drop into a whole new set of questions, which reflect the future, but which will determine the future, but also reflect what seem to be some significant errors of the past. That's kind of where I am now, and that's what we've been doing on the clinical research side. As outside of the Bellatrip randomized trial, this is what we've been doing, analyzing the Boost-2 data, and I think it's fairly interesting. And so what I'll do is stop talking now and open up for questions.
Great, thanks, Randy. Very interesting. Any questions?
Hey, Randy, that was a great talk. Really enjoyed it. Randy, what is your take on, having a more active approach toward measuring compliance? Do you think that's still something that you're interested in, or do you think it's going to be more passive evaluation? And I mean, I think your analysis is amazing, and I think really the shows the power of big data. But how much could we get of, like, again, measuring more compliance rather than sort of see what happens?
Well, when we started out back in the days of Douglas and Tony and those guys, we were measuring it. We were injecting 1 cc or sometimes withdrawing 1 cc from the EVD and looking at sort of the direct delta function, the immediate spike of ICP, and quantifying that. And, according to the compliance curve, it goes higher with the same injection volume if the compliance is low. And Tony actually turned that into, by exponentially transforming it into a simple number, the PVI. Unfortunately, when you do that, it was well documented that you increase the risk of infection. So open injection of fluid wasn't good for patients. So that kind of fell by the wayside. And also sometimes you would inject a cc, the ICP go up and stay up. So it was a bit dodgy. It was supremely interesting. And you would see times where you could predict intracranial hypertension based on compliance measurements. And then there have been a couple of attempts afterwards. Spiegelberg made a little device that looked like a Swan-Ganz catheter where you could inflate and deflate a little balloon at the end of a catheter and use that as the volume challenge. That was incredibly futzy and came out of a small center in Germany, and he just couldn't maintain it. A couple of us had it in the US, and we just couldn't make it reliable. It was, when it worked, it was great, but it wasn't reliable. And then there was some calculations. We look at the waveform to get compliance. And if the waveform can show compliance by changes in the relative amplitudes of P1, P2, and P3, then we can peel that out mathematically, right? Well, every time we've tried that, it's not worked exceptionally well. And then it's died out. And I think it's because people get tired of the maths that are involved. When you start talking about Fourier analysis and Bessel functions, people kind of turn off. And so that's fallen by the wayside. Now there's one group in Brazil, a group called Brain for Care, that's using a non-invasive skull elastometry monitor that is actually looking at the waveform again. And although they're trying to market it as an ICP monitor, what it actually probably is a compliance monitor. So I think there's still hope for compliance to become something useful at the bedside. And so I think, again, Tony and Douglas would say that's what we should be paying attention to, because if we just lower the ICP, and there's experiments showing this, if you do interventions to just lower the ICP and don't change the compliance, you'll be back 5, 10, 15 minutes later doing the same thing again. But if you can improve the compliance, then the same insult delivered later may not cause intracranial hypertension over a certain threshold. So I still think that compliance is the holy grail, and we may actually be backing into it via the skull elastometry device. But I think in the past we've given it up because it's been clinically hazardous or sort of too complex for us to want to play with.
Thanks. That's a good answer. Right? Amazing. Is there anybody working on new compliance? Dom, you're next. And new compliance devices that you know of, corporations working on new compliance devices?
Well, unfortunately, we've got the tattoo of ICP across our chest. We really bought into ICP. It became the religion of brain injury, and lowering ICP is successfully treating brain injury. And so it's become all about this number. And if you go to PubMed and put in ICP, the numbers are overwhelming. I think we need to change our orientation. There are people interested in compliance, and there are a number of groups working on it, but it just isn't well supported because I think it's not as easy to measure, and you know, it just hasn't caught on enough. It's starting to again,
Yeah.
but right now we're still behind.
Thanks, Randy. Dom?
Thanks. Awesome talk, Dr. Chesnut. I love listening to this stuff. It's really thought-provoking. I was thinking, you were talking about these episodes of high max ICPs where the averages don't exceed the threshold for treatment. And I was thinking to myself, well, why don't we just make the ICP monitor a 5-minute moving average so that we're not actually picking up numbers that would misdirect us in treating that? And then after thinking about that, I realized that there are times when the ICP elevates at a rate or to a level that is alarming for a clinician that they may want to intervene on in a more rapid manner. What would you say to that? Is that something that we should be teaching ourselves to ignore, to kind of average out those?
No. Well, that's a great point. Again, here, let's go back in the past. Lundberg waves. When's the last time we started talking about Lundberg waves? But that's the origin of the ICP monitoring and the recognition of intracranial hypertension. And certainly, if you have a spike to 70, that's probably not good for you. It represents some underlying pathology that shouldn't be there, even if it isn't a high average. So I think probably the main clinical implication here was what we think we're treating and what we're putting down on the chart is probably not what's actually going on. And that now that we have high resolution electronics in the background, maybe we got to use that tool to define our insults. And that could be more than one thing. It could be the area under the curve. So a high max with short duration may have the same AUC as a longer high average with less maximum. And I don't actually know. This would be a perfect time, if this can be confirmed, to put together a consensus conference for standardized electronically detected and displayed insults, which may include both.
Yeah, great. That's exactly what I was thinking. And then two other things that you brought up. I think, your study data is really awesome, and you had a very controlled environment that you did it in. But here in the U.S., like almost all tier 1 is done by nursing at the bedside, and so all your sedation and analgesia interventions are done well before a physician is even notified that there's a sustained elevation in ICP. How does that fit into the way that we practice here in the U.S.? And then I'm just going to throw this in there so that I don't take up too much time. But the last thing you said was, maybe we should revisit this dogma. I mean, I was taught very, very strongly that scheduled hypertonics, that sodium goals, that osmolar goals were not the way to handle ICP management, and that we should be doing episodic interventions. Are you proposing that we revisit this idea and start thinking about maybe setting goal-directed therapies in these areas?
Well, to answer the first part, I think that you're absolutely right. And again, that nurse saying fentanyl and propofol are maxed, and so therefore there's no adrenaline, and the patient's sitting bolt upright and the EBD is on wall suction. That's what we walk into. And why is it? Is it because we've decided that's the underlying pathology and this is the perfect treatment? Or is that because it's at the fingertips of the bedside clinician? I suspect it's the latter. And that means that we're not doing targeted therapy, that's for sure. And if you go to the literature and try to look at the understanding of the impact on ICPR compliance and the rest of the physiology of a brain injury of analgesia and sedation, you don't find much. So by far our most common treatments are really not very well understood. And when we talking about addressing pathophysiology, we just don't know what they're doing. It suggests we need to go way back and start over on what we do and have it not just be reflex to make the number go down, but say, okay, ICP is up, let's put our heads together quickly, or have a protocol to determine our treatment, not just what's convenient. The second is that I would have to answer yes, but in a qualified fashion. That's where compliance should come back. Douglas did an experiment with number of treatment agents in patients when they were still injecting fluid and measuring compliance. And he found certain agents, for instance, I think it was hypertonic saline, yeah, was very good at by bolus at lowering the ICP, but didn't change the compliance. Whereas other agents were good at changing both. And he made the statement that the reason the ICP keeps coming back when you're doing something that doesn't change the compliance is because you're not changing the compliance, and the same insult's going to happen again. The patient's going to get bumped or suction, or the blood flow is going to change. And if the compliance is crap, the ICP goes back up. So what I'm talking about, yeah, we should reconsider these titrations, not for sodium goals, but probably for compliance goals. Of course, oops, where's our compliance monitor? But yeah, I'm thinking accidentally by the best drip trial, the non-monitor said we may have backed into the idea of titration therapy, but we don't have a good monitor to tell us what we're titrating. And I don't think it's just how much sodium there is in the serum.
Right. Going back to compliance and ICP. Thank you, Rob Bono.
Thanks, Randy. Phenomenal talk. I think you've really shown that the emperor, i.e. we, have no clothes in this. And it shows just how little evidence we base our treatments on. So I wanted to ask your opinion about just how important it is for, for us to have kind of higher resolution, higher quality ICP and other continuous monitoring data while we're taking care of these patients, one. And then two, just kind of like, if you could fashion a crystal ball, we've talked all about, these form first, I can never pronounce it right, cliches, where ICP never required more than tier 1 treatment. What do you think we'd see in the more resistant cliches? Do you think you'd see a similar pattern or hard to say?
Well, that's a setup because that's our next step, right? I mean,
I know.
That's where we're.
Sorry.
You and I.
I'm asking you to predict the future.
I don't know. I think, yeah, I'm just a little troubled because of what we're asking the bedside clinician to do. I mean, how good are you at integrating in your head? While you're doing other things, while you're juggling balls and walking on slippery surfaces. That's a big ask. And yet that's what determines our treatment. And ICP, as Dom said, could be high, could be up for a long time, both. So I do think that we need a much more informative, non-subjective bedside display of pathology. I mean, like we have in the cardiac system where we've got all of these variables that are displayed. I think we need to question what we've researched and believed in the past, but I really think we need to change our display of data at the bedside. We will look into the more resistant ICP. I mean, obviously that's our next step, to finish that and look at that, and then finish what we do with individual treatments study. But I think the biggest problem is displaying what's ongoing in a way that's not subjective. That's been a problem forever, and we've never really questioned it. I think now we question it.
Yeah, in particular, we don't really know whether it's, what's worse, peak ICP, area under the curve, some combination, and it's just totally unknown at this point.
Right.
Yeah, the only way to find it out is to quantify it and study it.
Randy, there's a question that was posted from Amelia. Hi, Dr. Chesnut. Thank you for your presentation. Do patients with predispositions to having ICP events, patients with bleeding disorders and traumatic events, have a higher chance of getting resistant to ICP treatments? How would they delay an ICP monitoring in inaccessible settings for monitoring and transferring patients, for example, impact the patients?
Again, that's a great question. It leads back to compliance. And unfortunately, it's a great question without a great response. I hate it when I get questions that I can't answer. That one I'm readily say that I can't. If we had a better compliance monitor, we would know. We would even know who to put an ICP monitor in. And that's what we're trying to look into in Latin America as an upcoming study, is using compliance screening to determine who needs ICP monitoring, so we can not waste valuable resources. But again, it's about compliance. Predisposition to intracranial hypertension means their compliance is wrong, or else it means that they have high insults, like high blood flow variations, or they're under-sedated, et cetera. But that's going to be something we're going to need to come up with some actual monitors on and then look at.